Ma'am.
Recording, and then I'm going to share screen. Okay. Are you guys able to see that?
Yes.
Okay, thank you. All right, so respiratory, chapter 25 is your respiratory. The review, these are some terminology kind of things that you guys should keep in mind while you're studying, making sure you understand all of these terms. So atelectasis, that's the collapse of the alveoli. You guys can read all of these things, so I'm not going to sit and read them all to you, but remember that surfactant isn't produced until about 24 weeks of age. So if babies are preemies, they're for sure going to need some steroids to help develop their lungs. Okay.
Okay.
So remember that. Physiologically, your red blood cells or your erythrocytes, they carry the oxygen and to the tissues and the carbon dioxide to the lungs. Okay. Oxygen sats should be greater than 90%. Okay. And then here's some of your signs of respiratory distress. So know those signs. And if you know there's a question that's or a scenario that's describing, cyanosis or something like that, that you're caring then for a patient with respiratory distress. But I'm not going to read all of those things to you guys because you can read
Yeah,
them
you
all.
can just do like the important things or add-ons because I know like every professor they say different things or they add on different things. So that's
Uh-huh.
why I like to hear what every professor says because some are different than others.
Yeah, no, I appreciate that. So common respiratory illness, pharyngitis, so that's inflammation of the pharynx. It can be viral. Typically it's viral or strep, group A strep driven. Okay, so that's bacterial. If it's group A strep, you need antibiotics. So penicillin, amoxicillin, to be able to treat that strep throat. If it's not treated appropriately, you worry about things like rheumatic fever, glomerular nephritis, peritonitis, or excuse me, peritonsillar abscess, osteomyelitis. There's all sorts of things that can happen if strep is not treated appropriately. Strep also is a common cause of meningitis, okay, pneumonia, ear infections, all of that stuff can be caused from the strep bacteria. It's not always group A that causes those things. A lot of times it's strep pneumoniae, which is another form of a strep bacteria that causes more of the pneumonia and meningitis and ear infections. So URI, upper respiratory illness, that is if a child's febrile, making sure that you're giving them small amounts of fluids frequently to prevent dehydration. That's one of your biggest concerns as a nurse if they have an upper respiratory illness, so cough, congestion, fever, that they're going to become dehydrated because of their illness. So, and their work of breathing. So, making sure that they're staying hydrated is a very important piece for you guys as nurses to be aware of. Bronchiolitis, so that is like RSV. It usually occurs in kids age 2 and less. That's when it's most concerning. It can occur in kids older, but it's not as problematic for kids over the age of 2. It's also RSV is the most common cause of viral pneumonia across the board in infants. Asthma, you guys probably all are aware of asthma. That's one that's pretty commonly known about. So these kids are going to be wheezy throughout. They're going to need albuterol inhalers or nebulizers for their rescue, but they may also be on a corticosteroid, like a daily inhaler, like Symbicort or something like that. If they have more severe asthma or if they're having a lot of flare ups, that's usually what's added. Eventually, if their asthma isn't maintained well enough, they may have to do oral steroids as well. And of course, if you're giving kids oral steroids for lengthy periods of time, you worry about infection. Okay. Laryngotracheobronchitis or croup, right? That's the other name for it. That's inflammation of the upper airways, like a narrowing. That's where you get that stridor noise from. And it's a high-pitched kind of similar to a wheezing sound, but it's more high-pitched and it's upper airway. You won't hear this in the lungs. Okay. Epiglottitis, that is a straight to the ER, very emergent scenario. That's when the epiglottis becomes swollen and it swells, usually large enough to where it covers, the larynx. So these kids in the trachea, so the kids can't breathe. Most commonly caused by Haemophilus influenzae, which is that Hib vaccine that we talked about before. That's why kids get that vaccine. And Hib, also Haemophilus influenza, used to commonly cause meningitis in kids as well. Cystic fibrosis, this is a genetic illness. It's with these kiddos at birth. Usually parents know like right at birth or shortly thereafter that their kiddo has cystic fibrosis. It creates thick secretions not only in the lungs, right, but also in other tracts like the GI tract and the respiratory tract. So this is a multi-system illness. Okay, it's not just a respiratory illness. It falls in the respiratory category, but it's not just a respiratory illness. So these kids require high levels of protein and sodium because they're at risk for nutritional deficiencies. They also need pancreatic enzymes when they eat, so that way they can absorb the fat appropriately. Okay. They lose their electrolytes through sweat, so they're commonly in electrolyte imbalance, like hyponatremia. Okay. That's why they need a lot of sodium to replace their losses. They're going to have bulky, foul-smelling, frothy stools, and they will have likely struggles with infertility. Males specifically will be infertile until a year after they have a lung transplant. Okay. Women have less complications with becoming pregnant, even without a lung transplant. Okay, cardiac review. Wow, this slide is kind of hard to see. So these are your terms. So no tachycardia, that's faster or rapid heart rate. Bradycardia is slower. Okay, you guys should all know these. Dyscardia means ill or dysfunctioning, right? Hypoplastic means abnormally small or underdeveloped, okay? A shunt is where the blood flow is affected. So it's not going the typical way, it's going an abnormal flow direction. Murmur is the sound made from abnormal blood flow. It can be normal or it can be abnormal. There are innocent heart murmurs that kids just have, and they never have any issues with it. It's just they have a heart murmur. Cyanotic is going to be discoloration. They're going to be blue. They're going to have low oxygenation in the tissues. Acyanotic is they're going to have normal saturations. Okay. So that's how you look at cyanotic lesions versus acyanotic lesions for cardiac stuff. So if it's cyanotic, they're going to have less oxygen circulating. Okay. And stroke volume is the amount of blood pumped out when the heart contracts. And remember that the cardiac system is the first intrauterine system that's fully developed, okay? So it's very early developed, so there can be a lot of issues with it potentially. Okay, an ASD, this is an opening between the two atria. So you can see that here in this picture. There's going to be shunting with ASDs, okay? It's going to shunt from the left side, which has higher pressure, to the right side that has lower pressure, okay? So this is increasing the circulation of the blood to the lungs, which means Is it an acyanotic lesion or a cyanotic lesion?
Acyanotic. I'm easy.
Yep,
Okay.
yep, yep, because it's circulating more blood flow to the lungs. That is correct. Okay, and it's treated by surgery, or they can go in with a cardiac cath and do the closure via the cardiac cath at times, if it's not really a large defect. Okay, so atrial septal defects, ASD, is the opening between the two atria, and the blood flow is going to shunt from the left to the right atria and circulate multiple times to the lungs, which means it's acyanotic because that blood's that purple blood, right? Okay, VSD. So this is an opening between the two ventricle and the septal walls. You can see that in this picture as well. It's just between the two ventricles. So once again, the blood's going to go from the left to the right side. It's going to circulate to the lungs more frequently. So it's going to be an acyanotic lesion as well. Okay. Treatment is surgery. I've seen maybe one VSD in my career be corrected from cardiac cath, but most of the time they have to have surgery. Okay. All right, a PDA. So this is what the blood flow in the heart is while they're in utero. Okay. While they're in mommy's belly, this is the typical blood flow. They need that PDA, this opening, so that way their blood and their lungs are getting oxygenated appropriately while they're in mom's belly. Okay. So when the baby's born, within 24 hours, usually the PDA should close up because it's no longer needed. Okay. But at times it doesn't close up. So then they have to utilize indomethacin. Okay. And that closes that PDA up. Or if they try indomethacin and that's not helpful, then they have to do surgery. Okay. And this is also an acyanotic lesion. Okay. Sometimes too, blood pressure. I mean, obviously blood pressure with any cardiac kid is really necessary. Like it's really, really important. But with PDA kids, it seems to be a little bit more imperative to monitor more closely because they can have elevated pressures. Okay. Okay, coarctation of the aorta. So this is a narrowing of the aorta. That's what coarctation means, is a narrowing. Okay. So that blood flow is going to restrict the blood flow. That blood is going to be restricted from flowing to the lower part of the body. So think about like if you kink a hose up, right? Put a kink in the hose, what happens to the end of the hose that you're trying to use? There's not going to be very much water coming out, right? So that's essentially what happens with coarctation of the aorta. The periphery, so the lower extremities, have a lot of restricted blood flow. So the blood pressure in the upper extremities, if you do a blood pressure on the arms, it's going to be higher than those on the legs, significantly. Okay. So if kids, you suspect that kids have coarctation of the aorta, you should do a blood pressure on each extremity. Okay. This is usually done in the newborn phase around 24 hours of age. I have had one kiddo that got missed. That was a coarctation that I saw as a newborn. And they just weren't eating very well and things. So we ended up finding that they had significantly different blood pressures, and sending them to cardiology. These kids are at risk for CHF. So these kids are at risk for congestive heart failure if it's not addressed. Okay. So because they have a narrowing in the aorta, is it cyanotic or acyanotic?
Acyanotic?
Would it be
Sorry,
cyanotic?
which one? So is the
It's
circulation to the lungs affected in this development, in this, because it's the left side of the heart's what's being affected, right? And there's no shunting happening.
so it's no normal blood flow.
Well, there's no normal blood flow, but it's still flowing to the lungs normally. So it's acyanotic.
Okay.
Okay,
Okay.
it's saying like I was like, hey,
Yep. Yep. You were right. I just wanted you guys to think about it a little bit. Because even though there's less blood flow, the blood flow is still being oxygenated in
I was
this.
gonna say you made me think about it. That's for sure. Because I'm like, wait, am I right? Am I right? I'm like, what?
Nope, you were correct. Okay. Surgery, or they go in cardiac cathwise and they do like a little balloon dilation and they open that narrowing up to correct this defect. Okay, tetralogy of flow. HESI and exam questions, there likes to be a lot about tetralogy of flow because there's a lot of defects with tetralogy of flow. Okay. So it's one that they can ask you about that they need to make sure that you know, all the defects and what they do. Okay. So it's 4 different defects. They're going to have a VSD, they're going to have pulmonary stenosis, okay, an overriding aorta, and a right ventricular hypertrophy. Okay. So with the VSD, they're going to have that shunting, right? And then the aorta is going to be overriding. So the more of the blood is going to want to go from the right side in this defect because of the narrow pulmonary artery, the pulmonary stenosis. The blood's going to shunt more to the aorta, okay, because it's overriding. So the blood's going to kind of skip going to the lungs and go to the body. But in doing that, then it's going to be what kind of a lesion? Cyanotic lesion. Okay. These are going to be your blue babies. Okay. Because the blood is going to go the path of least resistance, which usually is left to right. But because of your pulmonary stenosis or that narrowing, it has a lot more resistance on the right side than typical. So it's going to go to the left side to the aorta. Does that make sense? Because your heart's having to work so hard against that pressure on the right side, that's where you get that right ventricular hypertrophy. So that muscle has to work harder on the right ventricular side than it
Yeah.
typically would. Okay. Does that make sense?
Mm-hmm.
Okay. And if you do an x-ray of these kids with tetralogy of flow, a lot of times it looks like a boot, their heart, just because of the hypertrophy of that right side. Usually the left side is more muscular, the ventricle, okay, because it has to pump further. But in this case, it's the right side. Okay, these kids are going to have TET spells. What do we do if kids have TET spells? Or what? I guess
Knee to chest position.
Yes, let me ask first, how does a TET spell look?
What do you mean by look?
Like, how does your patient who's having a TET spell look?
Don't they normally they'll be like running or something, and then all of a sudden they'll just stop and just punch to the floor? Like
Yeah, but do they have really good color? Are
no,
they like acting like a normal kid?
no, they're not
Happens?
acting normal.
Right. They're going to be blue, right? They're going to
Mm-hmm.
be tachycardic, likely. They're going to be, their oxygen saturation is going to drop drastically when this happens. Okay. But yes, you put their knees to their chest or have them squat down, and that will help get them through that TET spell. And the only way that they can fix tetralogy of flow is with surgery. And it's usually multiple surgeries, like in 3 stages. Okay. Okay, hypoplastic left heart. So this is hypoplastic means underdeveloped, right? Hypoplastic left heart, underdeveloped left side of the heart. Okay. These are going to be the extremely blue babies, okay? So this is a cyanotic lesion, okay? So look at this picture. Their left side of the heart is essentially not there at all, and their right side of the heart is a lot larger than it is typically, okay? So not only is the left side underdeveloped, they also a lot of times have an ASD and an underdeveloped aorta, because that goes along with the left side of the heart, okay? And there may be ductus arteriosus. So the these vessels sometimes can be flipped as well, okay? The ASD is necessary for mixing the blood. So if for some reason a kiddo that's born with hypoplastic left heart does not have an ASD, that's a part of the correction, is they will essentially create an ASD for these kids to be having some circulation or mixing of partially oxygenated blood going to the lungs, or going to the body, excuse me. Okay. 3 surgeries, all before the age of 5. They're all listed there. You guys might want to look them up. I don't know that I've seen like a huge, a lot of questions about the names of the surgery or anything like that, but to just know that it's multi-step approach to get these kids repaired, and the repairs typically happen very early on in age, okay? These kids, a lot of times, even if they are repaired, they don't have a very lengthy life, okay? Okay, cardiac continued. So diagnostic tests are arteriogram, so that's using x-rays and the aorta, and they inject an opaque material like contrast to look at that aorta and to see how it's functioning. Echocardiogram is ultrasound. They use sound waves to look at the anatomy of the heart and check into if there's stenosis or what that murmur potentially is causing on the anatomy piece of the heart. You get concerned about congestive heart failure in kids with cardiac defects, especially if they have a sudden weight gain, or they're just sitting there and they're having runs of tachycardia, or they're really short of breath. Okay. Common complications of kids with cardiac issues can be glomerulonephritis, otitis media, meningitis, pneumonia. That's just because of the increased demand on the cardiac system with those illnesses. And then also rheumatic fever. So if kids get strep, it's not treated, they can get rheumatic fever. That can cause various heart defects and damage. So kids who have had rheumatic fever then need to have preventative penicillin treatment. So penicillin prophylaxis to hopefully reduce their risk of getting further strep, further affecting their heart. Does that make sense? Okay. Congestive heart failure, we kind of already went through the signs. Early signs, your biggest cue is going to be sudden weight gain, especially with babies who are worn out while they're eating and they're not eating as much, okay? When caring for babies with cardiac or anyone with cardiac heart failure or congestive heart failure, you're going to want to make sure that you feed them before they're really worked up and crying, okay? You want to feed them early before they get to that point. Otherwise, they're going to be way too fatigued to even want to eat, okay? If they're really sleepy, you maybe want to let their feeding go a little late and try it a little bit later, okay? They're going to get less amount of feeding, more frequent intervals, okay? Because these kids are going to be worn out. If they're dyspneic or they're having low oxygenation rates, then they need to be on oxygen, okay? Medications may be prescribed or likely will be prescribed with these kids, and just making sure that they're weight-based, appropriate. Okay. And if kids are having a lot of weight loss or weight gain, vice versa, that can tell you a lot of times with kids with congestive heart failure if their parents or if the child's being compliant with their medications. Okay. Also, keeping track of INOs is important for parents to be aware of as well. Okay, rheumatic fever, we kind of talked about this already. It comes about after group A strep infection that goes untreated. It is a systemic disease, so it affects the joints, the heart, the skin, the nervous system, sub-Q tissues. So there's a lot of different things that go into play with this. Penicillin, like I said, is the drug of choice for treatment for strep, and then also prevention of permanent damage and further damage to the heart after rheumatic fever. Okay. Kids with rheumatic fever have to be on penicillin prophylaxis or some sort of antibiotic prophylaxis if they have an allergy to penicillin for at least 5 years. Okay. After the rheumatic fever. Now, there has been, so that's per your book to know about, okay? But there has been recent recommendations that if they had cardiac involvement with their rheumatic fever, that they continue penicillin prophylaxis for 10 years, okay? But for your book and testing, think about they have to be on it for at least 5 years, okay? Obviously, they're going to have joint pain, potentially red swollen joints can come about with rheumatic fever. They can get rashes that can be pretty painful. So you're going to give these kids anti-inflammatories and steroids a lot of times. Okay. Some of these kids may need to be on aspirin, but it's not a super common thing that they do. Okay. Aspirin is more for the cardiac concerns or, you know, risk of stroke or things. Okay.
Okay.
So not a standard thing that everybody with rheumatic fever gets put on. Okay. Okay. Hypertension. So we're going to put kids on a DASH diet, just like we do with adults if they're hypertensive. Okay. So that means low milk products, fish, poultry, low sodium, and more fruits and veggies. Okay. Hyperlipidemia. So this is elevated lipids in the blood. Okay. So fat or fat-like substance in the blood are going to be elevated. Lipoproteins contain lipids and proteins. So that's another word that you might see is lipoproteins. So low density lipoproteins, LDL. This is the amount of triglycerides and high levels of cholesterol and some protein. So this carries cholesterol to the cells and aids in cellular metabolism and steroid productions. Okay. So HDL or high density lipoproteins contain low amounts of triglycerides, little cholesterol, and high levels of protein. So this carries the cholesterol for liver to the liver for excretion. Okay. Okay. Chapter 27, blood disorders. Any questions from the previous slide or slides?
No, ma'am.
Okay. So blood disorders. Anemia is going to be your most common blood disorder, okay? Usually it is a nutritional reason why these kids are anemic. So most commonly iron deficiency anemia, okay? Anemic essentially just says decrease red blood cells or decreased concentration of red blood cells or a combination of both of those. So they don't have enough and it's not circulating like it should. Okay. Hemoglobin is the protein that carries oxygen. So if kids are anemic, and their red blood cells are low, their hemoglobin's likely going to be low eventually, right? If they're not making enough red blood cells, their hemoglobin's going to be low, and then they're not going to oxygenate as well. So eventually, if anemia isn't treated, you worry about cardiac failure. Okay. It can be acute anemia. It can be a chronic anemia. It can be an inherited thing from parents. It can be something that they acquire, like iron deficiency anemia, from not eating enough iron in their diet. Okay. And hyperproliferation, that means that there's a lot of destruction of the red blood cells. Hypoproliferation means that there's less destruction. Okay. And then, of course, decreased production means either loss, so they're losing those red blood cells in some way, whether it's a traumatic thing that they're losing a lot of blood, or it's just simply being destroyed via hyperproliferation. Okay. Okay, so like I said, iron deficiency is the most common form of anemia. Usually happens between 9 and 24 months. That's because they're weaning off their formula, which have iron fortified in them, and they are relying more on milk and foods. Okay, whole milk actually worsens iron deficiency large amounts. So if they already have iron deficiency, I would not be having them drink, a bunch of milk. Okay. It's also kids that are in adolescence, because of they're growing so much and their puberty and all of that, they're also at risk for iron deficiency anemia. So feeding them things like iron rich foods, so green leafy veggies, liver, red meats, beans, things like that have high iron in them, are one way that you can kind of improve that deficit. But a lot of times these kids need to be given iron supplementation. In order for that to be absorbed appropriately, they need to be taking vitamin C with that iron. Okay. Hemophilia is a hereditary blood disorder where the blood does not clot appropriately. Remember, there's different forms of hemophilia. Okay. Hyperlipidemia, that's excessive fat in the blood, which we already talked about that. Sickle cell anemia is hereditary. Red blood cells then look like crescents or sickled shape instead of being circular, so they don't carry that hemoglobin and as well. And they also risk, clotting up in the veins, that leads to those sickle cell crisis where there's actually cell death and past that clot. Okay. So if kids are in sickle cell crisis, they need to be not over oxygenated. They need to be making sure that they're getting plenty of oxygen, that they're hydrating, and then also that they're receiving pain medications, because it's really painful. Erythropoietin increases fetal hemoglobin, okay, which can help reduce complications of anemias. Okay. Thalassemia, that's a hereditary blood disorder where they don't produce enough adult hemoglobin, so they have a lot of fetal hemoglobin. Thalassemia major, or Cooley's anemia, is a severe anemia that eventually can lead to jaundice and cardiac failure. Okay. And then thalassemia minor, or beta thalassemia, is a trait, which means that they only get one copy from one of the parents, but they still have a mild form of anemia. But it's just not as severe as the thalassemia major. And thalassemia, remember who's most at risk for thalassemia? What ethnicity or Mediterranean people? Okay. So people from the Mediterranean are more at risk for thalassemia. What about sickle cell anemia?
African
African
Americans,
American.
And also
Hispanics, not Hispanic.
Mediterranean.
It is Mediterranean. I'm gonna say
Yep.
it is Mediterranean.
Yep. So same thing, just like thalassemia. Okay.
Okay.
And those are inherited things. Remember, we have to get them 2 copies from our parents to be affected. Okay. Unless it's thalassemia minor, which then we only get 1 copy from 1 parent. Okay. Leukemia. So the parent education that's going to go along with leukemia is obviously they're going to be on immune suppression treatments. So we're going to delay their live vaccinations because they're not going to have a good immune response to that vaccine anyway. So they're not going to create a lot of good antibodies. And also because they are at risk potentially at a very, very small chance risk of getting those live viruses if they receive those vaccines. Also, parents, if there's any fever at all with kids who have leukemia and are on chemotherapy specifically, they really need to be hospitalized to check into why they have that fever because they're at severe risk of infections. Okay. Meticulous oral hygiene because kids can have a lot of mouth sores after chemotherapy. And then skin, which then increases the risk of infection as well. And then skin, watching for like any skin sores or ulcers as well, because once again, infection risk. Okay. Okay. GU and GI. Okay. Dysphagia is difficulty swallowing. The most common medication, which we just talked about this, Arnisa, remember, is Tylenol. And that is purely because, or acetaminophen. And that's purely because almost everyone has Tylenol in the home. Not everyone has like aspirin or ibuprofen or things like that in the home, okay? It's most commonly Tylenol. So GI disorders, there's usually impaired functional integrity that then causes electrolyte imbalances or fluid imbalances, or there's disorders that involve GI losses. So large amount of fluid loss, or inflammatory disorders or decreased or excessive water intake can affect your GI disorders as well. So pyloric stenosis, that is projectile vomiting, okay? So like babies across the room and they hit the wall. Like that's how projectile it is, okay? It's not just spitting up and not bothered by their spitting up that's happening with pyloric stenosis. These kids go in immediately for surgery, okay? Meckel's diverticulum is an outpouching or a bulge in the lower part of the intestine. This is also surgical. Usually you remove that part of the diverticulum that's bulging and then reattach. Or sometimes if it's really significant amount of the diverticulum that's affected, they have to do like an ostomy. Appendicitis, still very common in peds patients, okay? So it's not like an adult thing. And if the appendix winds up rupturing before you figure it out, then these kids are a lot more at risk for sepsis, okay? And peritonitis, which is infection, with the abdomen, okay? So those kids require immediate surgery. So that way, hopefully that doesn't happen. They're going to have pain and tenderness in the right lower quadrant specifically. A lot of times they're guarding their belly. They do not want you to come near them. They're in the fetal position. If you push on their belly on that right at the McBurney's point, which is kind of right inner lower quadrant, they're going to have more pain with letting go than pushing. Okay, so that's called McBurney's point. Their CRP is going to be elevated. Their white blood cells are going to be elevated. You also want to do a UA because sometimes they're spilling ketones because of their appendicitis. Making sure that you do a stool culture to make sure that there wasn't some stool abnormality that potentially caused their appendicitis. Okay. CT scanned or an ultrasound. A lot of times now they are just doing ultrasounds on kids that they think have appendicitis first because there's less risk of radiation there. Okay. But if they get an ultrasound and they can't see the appendix and they're still pretty suspicious that kids have appendicitis, then they do the CT. Post-op care, of course, you're going to be doing anything like you do with post-ops, is managing their pain level, okay, and doing your labs and vitals. Hirschsprung's disease, this is a congenital anomaly that results in an obstruction in the motility of the intestines, okay? So what they do is they remove that large A ganglionotic, which means that they don't have those ganglion nerves in that portion of the colon. They remove that part, and then they lots of times have to have a colostomy bag for a period of time, and then they reattach the healthy tissue. Okay. Gastroenteritis, so this is an inflammation of the stomach and the intestines, usually caused from eating some poorly prepared meal, okay, or not totally cooked meal, or overeating or not mixing the formula correctly can cause GI stuff. But there's also viral illnesses that can cause gastroenteritis. So these kids a lot of times are going to be vomiting and having diarrhea. Because kids are having diarrhea and vomiting, you get worried about electrolyte imbalances. If kids are having a lot of diarrhea, what sort of imbalance are they going to have? Are they going to be acidic or alkaline?
Is it alkaline?
Mm-hmm. Good. Yep. And if they're throwing up a lot, they're going to be acidic, right?
Yes.
Okay. Good. So fluids on that one. Okay. Celiac disease is an autoimmune disease where the immune system overreacts to gluten in the gut. So it's a malabsorption issue in the intestines. Okay. These kids cannot have gluten. So wheat, flour, barley, oats, rye, none of those things. A lot of times they're going to do proteins, veggies, fruits, nuts, rice, beans, dairy, legumes. Okay. Hernia wise, you get concerned about an incarceration of your hernia, which means then the blood flow is cut off and it does not move easily back into place. So it cannot be reduced. Okay. If it's strangulated, then that blood flow is cut off. Okay. If it's incarcerated or strangulated, it's straight to surgery. Okay. If it's not reducible, if there's discoloration, a lot of times it's going to be straight to surgery. Okay. If it's easily reducible, like their umbilical hernia is, you can push it back in, then a lot of times the surgeons will wait until they're 4 or 5, because a lot of times those abdominal wall muscles will fuse totally and they don't have to have the surgery to repair it. Okay. Inguinal hernias, though, surgical, almost always. Okay. Acute glomerular nephritis, like we talked about, this is an allergic reaction to strep. Signs are a lot of times periorbital edema, so they're going to have swelling around their eyes. They're going to have pallor, so they're going to look pale, and they're going to be anemic. Okay. Chronic constipation, so fluids and high fiber, including both raw fruits and veggies in that diet. Okay. To manage chronic constipation, kids may also need to be on Miralax or something like that to help them poop, but ideally not doing laxatives every day. And Miralax is not a laxative, just so you know. It just pulls the fluid into the intestines. Okay. All right. GU disorders, UTIs. So this is most common in little girls because of our anatomy. Okay. So making sure that they're drinking plenty of fluids and that they're not holding on to their urine for long periods of time. That can be helpful in hopefully reducing the risk of reoccurrence. Also, not doing a lot of bubble baths and having them wear cotton underwear and making sure that those kids are wiping the correct direction. Hypospadias is when the urethral meatus is located on the underside or the dorsal surface of the penis. Epispadias is when it's on the ventral side of the penis or the top side of the penis, okay? In these cases, these kids have surgery at 18 months or earlier, and they usually are not circumcised at birth because they're going to utilize that foreskin for their repair. Cryptorchidism is failure for either one or both testes to descend. If they have cryptorchidism, they're at increased risk later in life for testicular cancers or infertility, okay? They have to have it either surgically, the whole testes removed, orchiplexy, or repaired and then sutured so that way it can't go back up into the abdomen and descend again. Okay, skin. Impetigo. So this is an infection caused by either staph or strep, and you're going to get those bullous, so fluid-filled pus kind of like lesions. Once those fluid-filled lesions kind of burst, then they get a dry honey-crusted scab on there, and they will need topical or oral antibiotics depending on how significant their impetigo is. A lot of times it's around the face, the nose, but it can really be anywhere. Okay. Ringworm, that's a fungal infection. It can be tinea corporis, which is body, tinea capitis, which is head, tinea pedis, which is like athlete's foot, fungal, okay, or curus, okay. Pediculosis is lice, okay, so you can have head lice, so pediculosis capitis, pediculosis corporis, which is body lice, or pubic lice, okay, which some people call crabs, right? That's like the slang term for it. Scabies. So this is a linear rash that's under the skin, really intense itching at night, okay? Most commonly like between the fingers, between the toes, armpits, groin, okay? But your key for scabies is really intense itching at night. They're going to need permethrin lotion, okay, which is a, oh gosh, why am I blanking? Parasitic, okay, lotion, and then also shampoo. Okay. Eczema is an inflammation generally because of hypersensitivities in the skin, which are almost always related to an allergic derivative, okay? So allergic causing skin inflammation. Burns are the leading cause of death in kids aged 1 to 4. Think about, they're really curious, they're touching things, they're grabbing things that may be hot. So the biggest concern is, of course, if they're burned on their face or their neck or their chest, you get concerned about airway. Okay. And the rule of nines, that's looking at the percentages of burns in certain places on the body. And then you also want to make sure with burns, they're going to have a very particular wound care routine. You want to make sure that they stay very hydrated, okay? And then you may even have to help them regulate their body temperature. There's a variety of different things that can cause burns: thermal burns, chemical burns, electrical and radiation burns, okay? Scabies, we kind of already talked about this, but all family members in the home need to be treated. Okay. Linens, all of that needs washed. Toys and non-washable toys should be bagged up for a week, similar to head lice. Okay. And they're treated with permethrin. Burns, like I said, it can involve different parts of the body, systems, skin, mucous membranes. It can go through the fat layer. It can go down muscular. It can affect tendons. I mean, it just depends how severe the burns are. Like I said, if the face is burned or there's concern that they inhaled, some of the smoke, but the heat from the fire, that can potentially affect their lungs. Okay. And they can have burns internally potentially. So your biggest concern is the patient's airway. Okay. With burns, if it's a weird pattern or it seems atypical, obviously you always want to have child abuse as a concern in the back of your mind, especially if that story is changing between the child and the parent or between the two parents. So make sure you keep that in mind, okay? Like I said, burns are more common in toddler age kids because they're curious, they're pulling on things, they're touching hot things. Okay. So instructing parents to child-proof the home. So cover outlets, adjust the water heater down so they're not, cranking the, getting into the shower and turning the heat way up and getting burns that way. They need an escape plan for fires and keeping the hot items out of their reach. Okay. And like I said, these kids with burns will be fluid resuscitated very rapidly. Okay. And you'll want to monitor eyes and nose and skin turgor and all of that. And also with burns, kids can present initially potentially with like almost minimal burns, but then as it continues, later in the day, the burns can become more prominent. Eczema, I kind of already talked about that too. So a lot of times it's allergy driven. A lot of times kids with eczema also have asthma or other food allergies. So your treatment is aimed at relieving the itching or pruritus, hydrating the skin, reducing inflammation, and preventing infection. So a lot of times these kids are going to be on fungals, potentially, antibiotic creams, steroid creams, and then a good hydrating ointment like Vaseline or Vanicream or something like that. A lot of times the eczema really flares in skin fold areas just because of the moisture. So keeping that in mind as well, keeping those spots dry. Acne, this is a pretty common occurrence in adolescent population as they go through puberty and their sebum increases. So talking with kids about routine skin cleansing with things like salicylic acid or benzoyl peroxide, not wearing a lot of cosmetic makeup while they have a flare up of their acne, okay? And then potentially they may need topical or oral treatments as well. Okay, metabolic conditions, thyroid dysfunction. So hypothyroidism, this is the most common endocrine disorder in children. It can cause physical and mental disabilities potentially if it goes left untreated. A lot of times these kids have growth restrictions or failure to thrive, okay? Diabetes mellitus, there's type 1, which is the lack of insulin. This is a lifelong disease, so they're always going to need insulin, okay? Type 2 is decreased insulin production, usually triggered from diet choices or sedentary lifestyle or obesity, okay? So that can be reversed. You almost always see type 1 in kids, but with childhood obesity increasing recently so significantly, we are seeing some type 2 diabetics as well in children. Your triad of symptoms is polyphagia, so constantly hungry, constantly urinating, and constantly thirsty, okay? Kids, a lot of times as they become sicker and their blood sugars become more dysregulated, they have weight loss. And also another key is they start having a lot of having to wake up frequently to urinate at night, or they start having bed wetting accidents or urinary accidents during the day too. So signs of hypoglycemia include irritability, hunger, weakness, decreased muscle coordination. They're going to be confused and they're going to be pale and sweaty. So you give them sugar to raise their blood sugar when they're hypoglycemic, okay? DKA, so that's going to be high blood sugar, okay? They're going to have ketones in their urine. They're going to have decreased bicarb and low pH. So they're going to become acidic, okay? So a lot of times this is when the metabolic acidosis comes in. They're going to need they're going to have hypertonic dehydration, fruity breath, and loss of consciousness or altered levels of consciousness. Okay. Teaching parents if they're traveling with a kiddo who has diabetes is important to talk about making sure that they have plenty of their medication prescriptions and supplies that they'll need on their vacation, but also having some sort of medical alert bracelet or some sort of medical alert for these kids is really important too. Okay. And then also wherever they're traveling, making sure that they're aware of the closest hospital if their kiddo would end up in DKA or something like that. Cushing syndrome, this is caused by an overproduction of the adrenal hormone cortisol, results in increased glucose production, and then fat accumulation on the cheeks, chin, and trunk. Okay, so these are those moon-faced, stocky kind of kids. Kids on steroids kind of wind up looking almost like they have Cushing syndrome potentially. Okay. So cortisol is a catabolic protein. Muscle wasting or protein wasting occurs that eventually leads to muscle wasting. So these kids are also going to have thin extremities. And then a lot of times they're going to have hyperpigmentation in their cheeks. So they may also have some more kind of ruddy red cheeks. Okay. Diabetes insipidus is the polyuria, polydipsia, and sometimes confusion. These kids excrete a large amount of fluid that causes an electrolyte imbalance. Okay. And with diabetes insipidus, it's not actual diabetes. Okay. Sometimes there gets to be some confusion on that, but making sure that they have current vital signs and you're keeping an eye on their blood pressure and their INO. Okay, I think there's only a couple more slides left, so I'm going to finish them really quick. Types of immunity. So this is chapter 32. Natural is what you're born with, right? Acquired means you're exposed to it as you get older. So such as disease or vaccinations, okay? Active immunity is when they're producing their own immunity. And passive immunity means that you get those antibodies to the person. So passive immunity in infancy usually occurs for the first 6 months. Kids have passive immunity and then their acquired immunity kind of takes over after that. Okay. Dosage calculations. Here's a YouTube video if you're struggling with that to review. In my course, I know that there's a specific worksheet posted for dosage calculations based off of his exam 3 questions. Okay, so go in and do that. There should be one also, Amanda, in your course. And if for some reason there isn't, you can email your professor, and if they don't get back to you on it, I can send you that.
Yes, ma'am. She did give me one. Thank you.
Okay, perfect. So any other questions that you guys have? Sorry, I kind of flew through that.
No, you did good. Like I say, it's nice to hear different takes on everyone because everybody like puts more information or adds on to it. So it's nice to hear different perspectives of it.
Yep.
And then it kind of coincide with what we learning in med search and what our test is on tomorrow. So
Yep.
So
Yep. It's just a little different because it's peds.
yeah,
But
it's Pete. So
yep. Yep. But yeah, it is nice when they start to kind of overlap.
yeah.
Yep. All right. Anything else I can do for either one of you guys?
No,
No,
sweetheart, thank
it
you
was
so
great.
much.
Thank
Okay.
you.
Yep. Thank you. Have a good day.
You
You
too.
too.
Bye.